Good morning, everyone. I would like to thank the APACI for inviting me today to talk about co-administration of COVID-19 vaccines. My name is Annelies Smith, and for the past 18 years, I actually lived in Singapore and was professor at LKC Medicine. But now I am in Switzerland and work for WHO as team lead for vaccine development. I would really have loved to be with you in person today, as I really miss Singapore. So what do we mean with co-administration? It is routine administration of all age-appropriate doses of vaccines simultaneously. And simultaneous administration is defined as administering more than one dose on the same clinic date, usually at different anatomic sites, and not combined in the same syringe. So it's not a combination vaccine. A combination vaccine would warrant an entire new lecture. So there are many reasons why we should aim for co-administration, and mainly programmatic ease. It's more cost-effective. It may result in higher vaccine uptake because a single visit is more convenient and it would be more acceptable to vaccine recipients. So there are many advantages why we should all aim for co-administration and ultimately, ideally also for combination vaccines. So during the initial 2 years of the pandemic, WHO had a recommendation not to co-administer any COVID vaccine with other vaccines at the same time. In fact, WHO initially recommended a 14 days interval between COVID-19 vaccination and any other vaccine, and many countries still do that. And the rationale for those previous WHO recommendations, which are now obsolete, was manifold. First, at the time, no data were available on safety and immunogenicity and efficacy if you co-administer. At the time, we were also still learning about the serious adverse events of COVID-19 vaccines and did not want to blur any safety assessments due to concurrent vaccinations. Initially, there was also a high priority to rapidly, that is the point, to rapidly roll out COVID-19 vaccines through vertical programs and campaigns and not waste time trying to decide which other vaccines should be co-administered. Furthermore, we learned that in 2020 and even up to 2021, due to the lockdown measures, there was an almost complete absence of influenza activity. That all said, co-administration was not stated as a contraindication in any of the package inserts. Inferring from co-administration studies of other vaccines, we know that most vaccines can be co-administered, but we have rarely also observed reduced immunogenicity and increased reactogenicity when co-administer more than one vaccine. Documented mutual immune interference has been observed, for example, for 2 live vaccines, yellow fever and MMR co-administration. Whilst immunogenicity remained the same for measles, GMT titers were lower for rubella and yellow fever. The same was also observed for co-administration of live attenuated influenza vaccine and MMR. There were lower GMTs for rubella. Now, the clinical significance of these lower GMT titers are actually unknown. We don't have real precise absolute immune correlate thresholds. Furthermore, it is important to note that the above observations were only made if live vaccines were co-administered, and therefore you will see for most live vaccines the recommendation to separate them out by 4 weeks. That said, we're getting now increasingly data that also for live vaccines, you either give them on the same time, on the same day, or 4 weeks apart. But real immune interference has not been observed for other vaccines. So co-administration with influenza vaccines was first to be decided upon. Obviously, the co-administration, or the advantages of co-administration, would be the higher vaccine uptake, which could mitigate an influenza rebound. Remembering that there was almost an absence of activity, we are all expecting an influenza rebound. And a co-epidemic of both diseases would put further stress on already very stressed healthcare systems. Both diseases are also associated with similar risk factors and therefore have overlapping target populations. And so the COVID-19 vaccine rollout could then benefit also from mechanisms already in place that many countries have in place for influenza vaccine implementation. So it would benefit both the influenza vaccine uptake, and the COVID vaccine uptake. And there is now really, as we're now transitioning from pandemic situation to endemic situation, and now our efforts should be to integrate COVID-19 vaccines into existing vaccination programs. So the first study to look at co-administration of COVID-19 vaccines with influenza vaccines was the COM-FLU-COV study. This was a study done in the UK with 679 volunteers, adult volunteers, who all had already received a primary dose, or at least one dose of the primary schedule for either the ChAdOx vaccine, the AstraZeneca vaccine, or the Pfizer vaccine. And so there were two arms. One was just the COVID-19 vaccine as a booster, and the second arm was influenza co-administered with the COVID-19 vaccine. And for above 65, they used the attenuated vaccine, and below the age of 65, they received the inactivated quadrivalent vaccine. And the results in brief were that concomitant influenza and COVID-19 vaccine administration was acceptable both in terms of reactogenicity and tolerability. And there was no evidence of negative immune interference for either of those two vaccines. And here you can see the GMCs. Those are the GMCs are GMR, sorry, the geometric mean ratio. And you see there all the confidence intervals all contain 1, meaning that the non-inferiority criteria were met. So this is reassuring both for the AstraZeneca as well as for the Pfizer vaccine. Another study, though, was called TAC-TIC, Timing and Sequence of Vaccination Against COVID-19 Vaccine and Influenza Vaccine. It was a single-blind, placebo-controlled RCT, and you see here there were 4 arms. The first arm was, so they all had primary series with a Pfizer mRNA vaccine. The first arm was 2 vaccines, then the booster doses separate by 14 days. First influenza, then COVID. And for the other arm, for the second arm, it was first a COVID vaccine and then the influenza vaccine. The third arm was concomitant, so simultaneous administration of both vaccines at the same visit. And the fourth arm was just as a reference arm, was the booster only, so COVID-19 vaccine only. On the right, you see the results of the IgG against the spike protein. And these are now measured as geometric mean concentrations at day 21 after the booster vaccination. You see that the baseline titers, the baseline concentrations are almost similar for all 4 arms, although that said, maybe in the so-called reference, it is a bit higher. If you then look at the first 2 arms, the influenza first, followed by COVID, and the vice versa direction, the GMCs were similar compared to the reference, which was booster only. However, indeed, for the combination, and I think they're using the wrong word here, it should have been the concomitant administration, you see that the GMCs are a bit lower than for the booster only. Of note, there are no confidence intervals here, and of note, the sample sizes are quite low, and we do not fully understand the clinical significance of this. We can only observe that here the GMC titers with co-administration are indeed a bit lower. So let's look at other studies. Reassuringly, here's another study from France which did not show any safety concerns nor immune interferences, neither in older nor in younger vaccinated subjects. So far, we've mainly talked about mRNA vaccines. So what about co-administration with another platform? And here, this is done a study by Novavax. Now, the NVX-CoV2373 is a protein-based vaccine, and in their phase 3 efficacy trial, they had a sub-study on co-administration. They did not find more reactogenicity in the co-administration group. And co-administration resulted, though, in some reduction in antibody responses to the Novavax vaccine, but not to the influenza vaccine. So they also reserved a reduced antibody response. But again, the clinical significance of this finding is unknown. So maybe it is of clinically higher relevance if clinical studies are done to look at the impact of co-administration on vaccine effectiveness in the real world. And so here, this is a study done in Italy that looked at this question for the 2022 to 2023 influenza season. The study was done in 942 healthcare workers, and here the results are really reassuring. So first of all, again, no safety concerns. Then they looked at post-vaccination breakthrough infections, so basically vaccine effectiveness studies, where they identified that about 40% of the enrolled subjects had breakthrough infections. So that translates into a real-world vaccine effectiveness of about 60%. But the rate of breakthrough infections was basically similar in the group who had received only a COVID-19 vaccine booster versus the group that had received both COVID and influenza vaccine co-administered at the same time. So I guess this is the most reassuring study. So what about vaccines other than influenza vaccines? This study here looked at co-administration of the Moderna mRNA vaccine with an adjuvanted recombinant zoster vaccine in adults aged 50 years and older. They found that co-administration was immunologically non-inferior to sequential administration and had a safety and reactogenicity profile which was consistent with both vaccines administered sequentially. So what are the policy recommendations? Here are the policy recommendations by the ACIP from the US. So they specifically say providers can simultaneously administer COVID-19 vaccine with influenza, with RSV vaccine, etc., for eligible patients. And then the most recent update that co-administration can basically be done for all vaccines, and the US ACIP includes childhood vaccinations here as well. Because, as you know, at the same time, there was also an Mpox outbreak. They have some specific recommendations for Mpox, that there is officially no required minimum, that we don't know the minimum interval, but ideally both Mpox vaccines should be given at least 4 weeks apart. And here the reason is the observed risk for myocarditis and pericarditis that we know for COVID-19 vaccines, but there is also such risk for the orthopox virus vaccines. And therefore, here as an exception, the ACIP recommends a separation by 4 weeks. WHO recommendations can be found in the WHO SAGE roadmap on the use of COVID-19 vaccines. And basically, WHO is really striving for a life course approach for the implementation of all vaccines, including COVID-19 vaccines, because as we said, such a programmatic approach would achieve a higher uptake of vaccines, increased efficiency of vaccine rollout, and protect already stretched healthcare systems. WHO did note that there were some studies that showed some reduced immunogenicity, but the observational studies did not confirm any issue. And even if there were a slight reduced VE, it would be offset by the higher coverage that you could achieve by co-administration. So WHO specifically now recommends that countries consider co-administration of COVID-19 vaccines with any other vaccines. And for influenza, we have a lot of studies. For others, we have to infer from other co-administration studies between other vaccines. So it can be either live attenuated, inactivated, adjuvanted, or non-adjuvanted vaccines that can be co-administered in adults and adolescents. You see here that WHO did not include children, and for children, because MMR vaccines are so essential and would and in terms of numbers needed to vaccinate, or in terms of deaths prevented, MMR is much more impactful than COVID-19 vaccines, and hence in childhood vaccination, WHO at this time still supports vaccinating separately. For maternal immunization, as you know, COVID-19 vaccine is strongly recommended by WHO as a single dose during pregnancy, and during pregnancy currently now also other vaccines are given in LMICs, especially, for example, tetanus, some countries also influenza, and maybe also in the near future RSV. So also during pregnancy, those vaccines can be co-administered. When administered concomitantly, the vaccine should be injected in separate sites, preferably in different extremities. And the reason for this is that there is local reactogenicity that you can then attribute it to the vaccine. WHO also recommends continued pharmacovigilance monitoring to ensure safety of co-administration. Thank you so much for your attention.